Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we hear from Mark Monaghan, WA Country Health Services Emergency Department Clinical Lead and the Director of Medical Services in the South West, about ensuring best care across Western Australia's medical system. This podcast was presented at Rural Health West's Rural Emergency Forum in October 2019.
I'm putting to you an idea that I've tried to pull together by talking to as many people as I can, from GP colleagues, training people, education people, the DMSs, and I'm going to have to sort of, pulling this together is going to need everybody to agree, and particularly WACHS hierarchy, and it's got some implications for everybody. So as much as anything today, it's sort of putting this draft to you and getting your feedback. If we don't have time within this half hour to get the feedback, we've got another sort of plenary session at 10:30 or something like that I was supposed to prepare and I forgot all about it. So we could talk about it more then. The sort of topics around really what we do about ensuring best care across the system, and as far as I can, and I had a chat to Mike Eaton, who's the GP ED the GP WACHS lead, and he told me, and I didn't realise this, but about 70% of our workforce across our state is IMG, and it's huge, and I had no idea it was that significant. And then we've had a long chat around how we find a way of clinical governance and maintaining or identifying our standard across the region. Now we know that most people are going to be, working at a very good or excellent level, and some people won't be. And I get involved in a lot of SAC1 reviews now through this role and my other DMS role, and sometimes the management in those situations demonstrates that somebody has not thought about their ED upskilling for a long time, and our historical thing of having the GP for the town supporting the ED, and we know that exists in lots of places, and I know some GP colleagues who've done that and still do that, and still come in and help everybody out at 2 a.m, and we've got a few down in our region that are just phenomenal guys. But how do we know where they're at in terms of their up-to-dateness from an ED point of view? And what do we do about that? And how do we help them sort of stay where they need to be so their patients and them and all their workforce don't get into a situation they don't want to get into? So sorry, I'm just going to go back. So when I was thinking about it, I mean, it's a matter of skills, it's a matter of what support people have if they need it. It's the right equipment in the right places, and I'll talk very briefly about that at the end. And it's the sort of processes around how they get what they need, and how we engage specialists and so on, that I think potentially ensure best care across our regions, and we need to optimise all of those. There's also a tension between workforce provision and standards. And indeed, anything you try and create that maybe gets more rigorous around standards, you've got a risk that you turn yourself into being in the too hard basket. And we rely on locums from eastern states, and certainly we get tons of them through our region. And if we change our rules and make them more onerous than another state, we just won't get people coming over and doing it. So we need to work out how we do that in a way that is reasonable and supportive, but also gets where we need to go. So, for example, if we decided that you're familiar with CASOP and the credentialing model, you got any? Yeah, some of you are, some of you aren't. So, just as background with that, when we, if you work in a WACHS hospital, even if you're a VMO or anything just coming in and doing surgery, you have to be credentialed for that job. And CASOP is the credentialing body. And so we meet, so often, and it's several hours of sitting there and going through the doctors that have come up for recredentialing. Now I think that there's a lot of work that WACHS needs to do in this space, because some of the credentialing would drive me mad if I was sitting there being credentialed as a GP, for example. Because, for example, if I've got Adam, who works in our region, who's works in Margaret River Hospital and Busselton Hospital, and then he wants to work in Augusta because we need shifts filled in Augusta, rather than just adding him on, Augusta on, he has to resubmit all his stuff to get added on for Augusta, and we all just go, oh my God, it's So we are working through that because we need to make that slicker. And so, but you will come to case op. So if we were going to review Adam, we'd come to case op, and he would submit all his paperwork and his working with children and his criminal record screen and his CPD. And then we would look at Adam and we'd look at him and say, okay, well, he's done this and this and this. No, he's rubbish. We're not going to credential him. And so there's a group of us that do that. And you have to have a quorum, and then we look at all the people, what the person's done, have they done React and so on, and ALS2, and how long ago they do it, and how much sort of currency they have with ED practice if we're looking at ED. And we would decide whether that person was appropriate credential for ED or not. And that happens all the time. We have one of those, probably every few weeks. And tons of doctors are going through it. And even any locum for 5 days has to be credentialed. So if we make that more onerous, we have a potential problem, because we will be limiting the locums that are available. And there's this other sort of this Country Health Initiative funding model that relies on doctors working independently in the sites that are being funded. And that's another complex thing, because if you brought in a system where some doctors, for example, were credentialed but only credentialed partially, like, required supervision, and GP registrar might fit that bill, for example, so they require supervision. But if if a non-GP registrar went somewhere and we said, okay, we have to bring in a supervision model for this doctor because they haven't got what they need, then you've got a problem in terms of funding. So that's probably not a thing you can easily bring in without impacting on funding for small sites. And we don't want to do that either. So there's kind of, sort of potential landmines everywhere where we look at this. One thing I think that's very clear from WACHS, and it's clear from Jeff Moffat, who's the CEO of WACHS, and the WACHS board, is that they are really committed to GPs being involved in their hospital system and encourage it, try to make it even more so. So we all hear about challenges around GP anaesthetists or GP obstetricians in certain areas, and are they going to be taken over by specialists? And I'm quite familiar with an argument in a certain area at the moment where the specialists feel that they would do a better job of managing that, and they could cover this particular site, and that a GPA model is a less attractive option in terms of patient care. But WACHS has quite the opposite philosophy. It sees value in that, and certainly as a Director of Medical Services down there, I see real value in having GPAs and GPOs continuing to be the core body of work for those specialties, because they have a whole different, envelope of skills, and they support our hospital. So if I've got relationships with them because they're in our hospital doing their anaesthetics and doing their obstetrics and working in our ED, and they're working out in GP practice, we've got a safety net that's created by that. And I think, and they offer skills even within the GPA setting around knowledge about medications and stuff that the patients will be on that the anaesthetist may well not have as intimately. So I see real clinical value in that. So in ED, it's exactly the same, and we have a lot of GPs working as SMPs in our ED, and they're brilliant. And I work alongside them as a FACEM, and I struggle with the balance of clinical and admin at the moment anyway. So I feel, as sharp as a bowling ball most of the time now. But I have the guys next to me from the GP, ED, SMP point of view that I learn more from than they learn from me. So that exchange of skills is really great, and I think it makes a really good department. And the other thing is that the rural generalist train has taken off well and truly, and so we're going to have ongoingly have a lot of GP specialists in the realm of our EDs and our other specialties. So as I said, credentialing is required for every clinician. Each clinician is discussed at a case-op meeting, and credentialing for GP specialist doctors for disciplines where they're a specialist is a tricky area. That's a really complex sentence to write. When I first wrote this, I wrote GPs where they're a specialist in the tricky area, and then one of my GP colleagues on the emergency medicine leadership group contacted me and said, come on, mate, get a bit more politically correct here, and said that the GP specialist, and it's quite right. But then the sentence gets all complex because you have specialists all through the sentence. But so I apologise for the lack of neatness of that. But I've got it more politically correct now. So credentialing a GP specialist in the area of ED or anaesthetics or obstetrics is the tricky bit. So, but the GP anaesthetists do it well, and so do the GP obstetricians. So they have a non-specialist anaesthetist credentialing summary that anybody who's a GPA has to complete, and that covers their qualifications, where the doctor intends to work, their currency of practice, and they will have a logbook around certain anaesthetics that they've done, and any upskilling they've done, and the scope of practice requested. And that goes to my equivalent, which is Pat Coleman in the GPA world, in the anaesthetic world. And then if you meet all those, you are ticked off for credentialing, and you continue to be a GP anaesthetist. And if you don't, then there is a process whereby you can go do some upskilling, or your credentialing is limited to a certain scope of practice. And that works really well, I reckon, and it's neat, and it's consistent to each clinician, and I think it allows for a maintenance of standards. So I think it's a really good model, and the obstetricians have got a similar one. So you would have something like this. Apologies for that slide, I couldn't quite make that work. But you could potentially have a similar thing for GP anaesthetists, GP obstetricians, and GP ED. But then there's a few things in there that are tricky that we'll talk about in a sec. So that's kind of the theory about where I'd like to go with it.
Excuse me.
Yeah.
There's a glaring one there, and I know people will disagree with me. And it's volume of practice, and it's not up there. And we get locums come to our site who can say that they've got JCCA. They can say that they've done a recent general anaesthetic. They can say they've been to a recent ALS2. They've got a logbook that's got X number of cases in the last 12 months. They can say that they do scopes and obstetrics or whatever. They've been signed off by Pat Coleman. They can list the sites that they've been at, But then when they actually get their hands on the ground, they shit themselves in front of the first patient. And it's really, as I'm flying out of town, I fear for my community sometimes.
So I think it's a really good point. I don't think any of these things are foolproof or complete. As I understand it, I'm not a GPA, but there's a few in the room that you have to put down the number of particular things that you've done for each of those things. That's correct, is it not? Yeah.
The practice isn't really considered of importance, and I know it's a bugbear of mine, but anyway.
Sorry, say that.
Volume of practice isn't considered as weighty as recency or ALS2 or something like that.
Well, I think, except that I think kind of the opposite, in that I think that that you can't pick a good person by whether they've done REACT or ALS2 or anything like that. I think you can get a feel, like if they're completely not in the ballpark, you can get a feel for it. But to tell somebody's good, you have to work with them.
Yeah. And of course, you can do a lot of cases badly. And so I know volume practice is flawed, but yeah. Yeah,
so everything's flawed, and I guess but what you're trying to do, what I'm trying to do is try to find some middle path here that gives some sort of structure to it, even though we know people are going to slip through that net. But at least it's better than not having something at all. But I totally take your point. Yeah. And by the way, if anybody has something they want to say during this is much more of a conversation than a thing. So just do exactly that. I think that's because that's exactly what when they do their NSACs, they have to say how many cases they've done. I presume you have to keep some sort of logbook to support that. Yeah. Yeah. So it would be hold on one second. It'd be tough to sort of police that, but the other thing with that, just quickly, is that another part of that is not tolerating people being less than good. And there is a tendency amongst us as clinicians to, if we know somebody's a bit of a muppet, we kind of let we're not good at calling that out and doing something. We kind of like, we'll sort of help them out and be there, and I think that's a problem with us as a profession. I think we allow too many people to continue to perform at a level we wouldn't want our families to look after, because it's really uncomfortable to deal with it. And I think that's a real problem. And for better or worse, part of my role as a DMS is to actually address those people that maybe their colleagues haven't wanted to or haven't felt empowered to do, which is horrible and unpleasant. But we kind of have to do that. We're not good enough. And yet, we want the best for our patients. So I don't really want to talk about GPA anyway. It's, but I just wanted to use it as an example, but I will talk about exactly that in a tick. And the way I'm going, we may well have to use the extra session, Scott, to talk about the other stuff. There is a rural generalist program now that is well funded, has been supported across the country, and will be guiding the creation of what you were when you did that. So it creates doctors that have a good range of specialties, and they'll be able to specialise in some particular thing, whether it be surgical or anaesthetics or ED or something like that, as an extra skill on top of that. And they will be going out to support rural sites with that range of skills that traditional GPs used to have. And so there's a lot of money behind it, and it is being talked about a lot. I'm not driving it, it's sort of separate to me. Scott, is anybody talking about rural generalist stuff today or tomorrow? No. But it's probably something that I don't know, maybe at the conference it may be is it worth seeing whether that's included in that, because it would be obviously important for all of you to be aware of. So young doctors are coming out with the sort of skill set to be able to go out to somewhere isolated and perform well, and indeed have extra skills in certain areas, and we'll talk about that. In many ways, as you say, we've moved from the docs that can do everything to making it tight, and then they haven't been able to do everything, and they're trying to create doctors again that are good across very good across a range of areas. So it's fashion. my genes will come back into fashion at some point. It's no, I think it's good. I think it's great, but it's got its complexities too. Anyway, I'm not across it enough to talk about it in too much depth, except to say that exists. So ED credentialing. We don't have a credentialing form. We don't have the NSACs like the anaesthetists do. Our criteria are less standardised. So if we will hear about the person's qualifications, about their ED experience and what courses they've done. Have they done a REACT in the last few years? Did they pass or did they not pass it? And then we'll kind of make some sort of decision on whether they should be credentialed or not. And if it looks a bit tenuous, then we'll say, okay, well, let's get them to get an ALS2 in the next year, and we'll give them a year, and then we'll have another look at them. One of the things we don't want to do with credentialing is continue to people just for a year, because it's a pain in the neck for you guys, and it's a pain in the neck for us to keep going to these meetings and re-credential people have another look at them in a year's time. So it would be lovely to create a model where we have a really clear guide, I think, like the GPAs, about how we're going to do this. We don't have any clinical lead reviews at this point, except for if an issue's been raised, and this has started happening more recently, about a complaint has been made against a doctor or, by another colleague, or there's a concern that's brought up and it comes to WACHS Central, then they will come to me and talk about that, and it may well be that we get that doctor sort of, somebody goes and spends some time with that doctor. I've done that with one doctor personally, and but you can also, we'll talk about which other ways you can do that. So it's ad hoc at the moment, and when it's ad hoc, you've got to be careful, because you don't want to be seen to be just targeting an individual. You want to have a system that applies equally to everybody. I think it's really, really important. So we all feel, EMLG, just for those of you who don't know, there's no reason why you should know about it, but it's the Emergency Medicine Leadership Group. So it basically has a rep from every region, and a GP rep, and a nurse practitioner rep, and an ETS rep. And we meet sort of via VC once every month or two, and we talk about stuff that's happening across the region, how we can make things better, and I communicate stuff back out to them that they can do. So that's a bunch of people. Some of them are FACEMs, some of them are GPED, some of them DMOs. So it's got a reasonable range of people, and it's good, and they're all clever, and it's really helpful for me. So So we need, because and what I think why, I don't need to say to you why. I mean, we have very good reasons why country medicine is different, and we need to have better people out there that are up to skill in everything they need to be. We don't have specialists around. We don't have ICUs. And we don't want doctors to go through the sort of stuff that you go through if you have to get involved with APRA or a SAC1 review or anything like that, if we can avoid it. Tough on them, tough on their community, and obviously most importantly, we want patient care to be as good as it can possibly be. So more than Metro, we've got reasons to do this. So this is a suggestion, and I base this on talking to lots of different people. But there'll be holes in it, and there'll be things you can see that are problems, and that's kind of why I'm presenting it. So the way I see it, there are 4 distinct groups. There are holders of advanced ED training, and that's probably going to be FACRM graduates that have done sort of extra ED within their training. There are RACGP graduates that have got an ASIM diploma because they can get an ASIM certificate or diploma. The diploma is the longer one. That's the 18 months. It's 18 months, isn't it? I think it's 18 months. So there's that group. And for them, I think it's quite different to the other groups in terms of how we approach it. We've got GPs servicing their country town ED. Lots of people like that around. We've got IMGs and we've got short-term locums. And the short-term locums are often the scariest bit because they'll come in from somewhere we've never seen them before, we don't know them, or indeed some of them who might be, may not be particularly good, often sort of region shop as well. So how we get a handle on that, and it's very hard and it's very time consuming. So they're the 4 groups as I see it. If we create some sort of post-locum quick assessment, like a single sheet, this person was fine, this person wasn't, we've got to be really careful about not adding paperwork because paperwork for all of us is the bane of our lives and we've got to watch it. But if we could create a central repository of those assessments, electronically, we may well be able to sort of augment that issue. Now we've got ETS, and ETS has changed the game quite a bit, hasn't it? But ETS, again, I mean, they're brilliant. And for sites where the nurses are used to ETS, it works well, but it's still tough for them. It's tougher for them than not having a doctor handy. And I've got one site that they're just not used to not having a doc around. And when they have to do it, I mean, it's sort of like, it's an angst thing, and people have to grow into that. You can't just dump it on them. So... but ETS has made this potentially a bit safer. But again, for the doctors that are, and again, I'm preempting what I'm going to say later, but for the doctors that need support, the question of where ETS fits into that is an important one. Okay, so there's no way I'm going to finish all this, so maybe we will talk about it later if you're interested in talking about it. I think for me it's, this course is for you guys, not for me, but it's really helpful for me to hear the feedback. For just getting through some of the simple ones, so for holders of advanced ED training that we talked about before, one potential approach is that we go to 4-year credentialing. I think a lot of them get 3 at the moment. Do most of you get 3 years when you get credentialed? Yeah. So as I understand it, and again, it's all things are changing all the time in here in terms of my understanding of it. But ALS2 and APLS all last for 4 years. So you could shift it to 4, make it a little less onerous on you guys, a little less onerous on us to keep credentialing. But as long as you've completed specific courses, now even that's quite a big discussion in itself, because the purists within our group would say you should do APLS, ALS2 and a trauma course, and they're the only ones because they're robust and they're assessed. And that the Western Rural Trauma course or REST or any of these, or REACT for that matter, aren't quite, some people say they're not quite there and so you shouldn't use them, so you should be rigid about that. I think there's a really interesting discussion around REACT, and I had a long chat, and Scott's very familiar with REACT, and I had a long chat to Tony Salenza, who is, lots of you probably know, who's a really, very reasonable, smart guy. And Tony said that we're talking about the origins of REACT, and you guys probably all know this, but it was initially created as a credentialing tool. It's not that now. Thanks, Kate. But it's and a lot of people enjoy the course, as I hear. I get a lot of good feedback about the course, and it's got a degree of assessment, which is, but not quite formal, is it? But it's still, you assess and you observe while you're doing the course, and if you've clearly got no idea, then that will be identified during the course. But again, it's a snapshot, isn't it? I mean, people can pass a course and still not be good in real life, but it's something. So Tony and I have talked about, is there a way to sort of just bolster it a bit and then include it in this cohort. And I think probably we will do that, because we need lots of opportunities for people to upskill. We can't limit it too much and make it really tricky to get what you need to get. And we know that within our regions, ALS2 might come around once a year, or it may not, depending on what their resources are. Now, there's lots of private providers and things, but it's got to work for everybody, doesn't it? It's got to work for availability and time and so on. So I think REACT should be in there, but probably there's a lot of courses that are really good to do in terms of just familiarity that probably won't be included in this credentialing thing. And there'll be argument around that. There will be the people providing the courses will be upset if they're not part of that, and it's a tricky conversation, but that's part of the joys of my job. And that neonatal resus and obstetric upskilling for those that have to deal with obstetrics in their EDs would obviously be really encouraged. Neonatal, I think particularly, in fact, personally, I'd love to include it as a core thing, because it's quite a different gig from anything else that we do. It's horrific when it occurs, and it would be lovely to be kind of at least keeping people in the space on a regular basis. And evidence of regular ED practice, logbook. And then there's the big question about logbooks and how you do it. And I'm going to get to that in a little while, because I don't see... I've had a good chat with a few colleagues of mine, some of whom are here, and I don't... we couldn't see how... If I try to picture, when you create these things, you then try to picture a particular doctor in a particular place, and there's a doctor in Lake Grace, and they're not seeing ones and twos for, hardly at all during the year, and they haven't had to put a chest tube in for the last couple of years because the job just hasn't required it. What do you do when you've got chest tube on the logbook? I mean, how do you make that work for them? And so it doesn't make a lot of sense. And so we thought up a different way of approaching that, which I'm going to tell you about, if not now, then in a little while. What we haven't decided yet, and that's why part of this consultation, is that what should be defined as somebody who's got the ED expertise, that they don't need to have extra bits.
But this is what they're all about.
Yeah, and I'm going to talk about that more as we go along, but yeah. Okay, look, thanks a lot for your time, and we'll chat again afterwards. Yeah. So for those of you who weren't, a few of you weren't here this morning, but basically, so I'm Mark Monaghan, and this talk is basically, from my perspective, as the ED clinical lead for WACHS. And what we were talking about is how we create a more robust clinical governance framework and sort of platform for credentialing doctors, so that we know that the people that are out there doing the ED work are we're in a good place, and then if there's people that aren't quite up to that we're able to identify them, because we really have no real system of doing that at the moment. There's these four groups, and that's what we were talking about. We were talking about the holders of advanced ED training, so people that have been through the College of Remote and Rural Medicine, or with an ED extra component, or the RACGP people with the ASIM diploma, and those sort of people are quite different. And then we've got the GPs servicing their country town, the IMGs and the short-term locums, and each of them probably need a slightly different approach, as I currently see it. But again, as I said before, this is an exchange of ideas, so nothing about this is dogmatic at all at the moment. I'm just trying to gain enough info to get something sensible out. So we talked about these guys, and we said that we'd be looking at 4-year credentialing in line with the ALS2 APLS sort of period that's applicable for, and then you have to repeat, and neonatal resus and a logbook, and we're going to talk more about logbooks in a tick. So I think that's reasonably straightforward, and what I don't think we need to do with that group is include a sort of a clinical review process, because they've really gone through a fairly rigorous thing when they've got their training, and I think that would probably be unnecessary, and all the clinical review aspect of what we can talk about is going to be incredibly time and resource intensive, so we want to put it where it's going to be most useful. So the next one is the GP servicing their local ED. And let's put my cup down. Again, I think that we could look at 4-year credentialing along the lines of the courses that we talked about before, and the courses would be the same and the logbook completion would be the same. And again, I'll get more into detail in a sec. But there would also be, in this model, an initial clinical review. Now you could do that by, you could just say, look, now's now, and anybody new that comes in will do that. But most people feel, when we've talked about this, that it's reasonable to go back and clinically review on the basis of when your next credentialing comes up. Now, this is going to be quite a challenge, and we're going to talk, I think I put it in the next slide. We have the question of how we do this, where we do this, and the issues around it. So our current thinking is this, that when you come up for credentialing and you're a GP servicing your local hospital in the town that you live in and committed to, that you have this, but this initial clinical review will take place, and that is potentially something that you might do in 2 days at the regional centre, where they just, you do some cases there and they go through some stuff with you with a pre-formatted core subject-based assessment. So we will make sure that everybody gets discussion around acute asthma or paediatric cases, or sort of things that would be expected to be reasonable core business, and if you came across one and it has quite significant sort of implications, if they're bad, that you would have a handle on how to approach that. And then we would come out with some assessment, yes, this person is capable and has a good headspace around these things, or they don't. The alternative to that is that somebody comes out to meet you and spend a day with you, and that might be me as the EM clinical lead, or it might be an ED clinical lead for that region, because most regions have got one, and they'll come and spend a day with you, or it might be a GP ED person that's come through WACHS with their extended ED skills that is identified as being somebody that's appropriate to do it, and they come out and they spend a day and they go through again a pre-formatted set of sort of subjects, and I think personally, and we could all, people have different views on this, but I reckon I could sit with somebody for a day and know where they're at and whether they are safe and whether they've got a good head for ED things. And that doesn't mean they're going to know everything about everything, but they're a common sense person who's got good muscle memory and knows when to ask for help, and they're safe. So I reckon I can tell if somebody's safe. I reckon I can also tell if somebody doesn't really have a structured approach to fairly, common, significant presentations. And so that's a second option. And the third one is maybe React. And again, bolstering React to come back to being a credentialing course and making sure it's got what it needs to have to identify the people that don't have that structured approach to things and may be a concern from that point of view. So we probably need options, because it's going to be too much of a gig for me to go around and clinically review everybody in the state that needs their clinical review done. The regional centres, there's implications for them in terms of having somebody, sitting with them for a couple of days, and for the doctors going to those regional centres and spending 2 days out of practice to go and do that. And there's a whole lot of work that we need to do around looking at what funding model supports that in terms of your ongoing education and CPD and so on, and how we might support the regional centres. Certainly the clinical leads in the regions can do that on non-clinical time, or if they've got an MSA they've got normally got a non-clinical component to their MSA, so they get paid $100 and something or other an hour to go and do non-clinical work, and they could do that through that. And then there's a React course, but React course generally takes about 18 participants, I think. Is that right, Scott, about that?
Yeah, 18.
Yep, and there's not many of them, so you may get into one, you may not. So we have to have options for how we're going to do it. But I think what that allows us to do, this is just a one-off. You wouldn't need to do this every time you're credentialed, right? This is just a one-off. So everybody, we just basically touch base with everybody, and we know where everybody's at. And then you wouldn't need to do that again. Just like me being a FACEM, I don't need to go back to the college every 3 years, and they don't need to retest me, but I need to maintain my CPD and my logbook. So to me, that's not not an unreasonable thing to do, but it could be quite a confronting thing to do. Because if I've got if there's a GP in a country town who's been an incredibly good GP all their career, and then they have somebody coming to them and spending a day with them, assessing them, that has to be done in a particular way, doesn't it? Because that could go totally pear-shaped. And some people won't want it, and some people will be challenged by it. Other people might welcome it. And we have to, whoever's doing this, we have to make sure that they're approaching it in a mature, respectful, collegiate way, and we work it in with how it's going to work best for the GP, whether they want somebody to come out or go to the regional centre or do the React. And so we kind of make it user-friendly, but also make it non-intimidating. I think you can do that, but it takes some sensitivity, and the sensitivities are obvious, I think, aren't they? So for international medical graduates, potential approach, there is something here. I mean, again, the 4-year credentialing requirements as for the GP thing, but we would probably look at some currency of practice as well. So maybe they've done 6 months of ED in the last 12 or 12 in the last 24. But ideally with a FACEM or DMO sign-off. So if they've worked in other places in Australia, and they've worked in a department that's big enough to have a DMO lead or a FACEM lead, and they get tick off from that, then they don't need a clinical review, because I think that is the clinical review. But if they haven't had that, then they would need one. So again, we're talking about a lot of doctors, potentially. But again, I think we just can't have a situation where we're not at least having a look at this, and then it would go on and they'd have a 4-year credentialing cycle. Again, it would just be a one-off clinical review. Locums, again, are trickier. We get a lot of locums for 5 days coming through our hospitals. What do you do with them? Well, I don't think you can actually easily sort this. Again, we would look at their recency of practice when they come to CASOP. So we'd look at their, have they done 6 in the last 12 or 12 in the last 24? We'd look at their CV and the amount of ED they'd done. We'd look at the courses they'd done. But I think for the short ones, in the end, that's probably the best vetting we're going to get, except if we look at the post-locum review, if we set that up. And that may well be quite a useful tool to have ongoingly, because that's allowing us the clinical review just by nature of the fact they worked with us. And it may not be as structured, but it will give us an idea of people that we've just got to watch out for. So I think if they're less than 3 months, there's probably not much we can do clinical review-wise, but if they're a long-term locum, we would institute the clinical review as part of their credentialing. We couldn't keep up with the shorter-term locum ones. And they would have a shorter credentialing period as locums. So the sort of questions I'm wrestling with at the moment is how we best utilise the clinical review. Will this result in increased workforce pressure? I have heard about a scenario where somebody, the need for a clinical review was raised, and a very sensitive, kind person went to do that, and it turned into an absolute disaster in terms of the relationship between that person and the one going, because they just didn't want to be challenged on what they were doing. Now that in itself is alarm bells, I think, anyway. But will it mean that locums don't come because they don't want to have a clinical review? Is that a bad thing? Well, it may not be if they're worried about having clinical reviews. How useful will a logbook be in the ED setting, and is this whole approach workable and palatable? I'm going to talk about the logbook in a sec, but basically the outcome of any clinical review, well, if it's satisfactory, no need to repeat it unless concerns are raised, like there's a SAC1 and there's a particular deficit that comes out, and then maybe something has to happen as a consequence. And as you probably know, with the SAC system, with the clinical incident review, there'll often be recommendations, and part of the recommendation might be, for example, that I or one of my colleagues go out or a local colleague, if it's less intimidating, goes out and spends some time with that person, or just has a chat about where they're at and try and talk through that. If the clinical review is considered unsatisfactory, then it would be reasonable to give them another go and bring them into a regional site for 5 days and spend time, or indeed an outer metro site or a tertiary site. depending on what our relationships are with those centres, and see where they're at. And then if they fail that, because that's the second option for them if they haven't done well in their clinical review, and there won't be many people that are in that basket, it'll be tiny numbers. And if it remains unsatisfactory, not for recredentialing until they meet certain criteria. So that's kind of how it would play out. The logbook's tricky. So when I was chatting with my colleague who's in this room about how we might do that, we were talking about, chest tubes and that kind of thing, and we decided that it just wasn't workable. So what we thought instead that maybe a workable solution is that you keep a record of your ATS presentation, particularly if you're in a tiny site. And in a site that's supervised by FACEMs or DMOs or something, none of this is relevant, right? Because there's a system within that to keep an eye on things. This is people that are working in much smaller EDs and aren't being supervised. And then if they've had low numbers of 1s and 2s, they may well be offered upskilling in a regional centre or indeed in ETS. 40% or so of ETS's calls are 1s and 2s. So you've got a really, rich source of management of acute problems there, and you could sit in potentially with ETS for a couple of days and just go through them and be thinking about them and thinking about your approach. And I've spoken to Justin Young, who heads the Command Centre, which is overseeing ETS and mental health ETS and ITS and all those things that you're all sort of experiencing now. And we're looking at how we might make that work. There's a really good chance that will be something we can do. The other question is mandatory involvement of ETS for 1s and 2s in a place, some place where that hardly gets any, and whether, if we've got somebody there who's hardly seeing any, whether you bring in a system where for 1s and 2s they simply call up ETS and have a yarn and go through it with them, and there's a learning opportunity and a better care opportunity. Now, ETS are exploding. They're also covering all our gaps when we can't fill our weekends in places and things, and their number of cases, I'm talking about again a little bit later on, but their number of cases is getting huge. So we've got to be careful about how we use that resource and what it actually can provide. So Justin and I are having constant discussions around that because we don't want to mean that your wait time to get an urgent case is seen and stuff. We've got to be careful about the resource and how we use it, but it's a bloody good resource, and we should use it in clever ways to improve care. The other thing that happens, that should happen with this, that I believe, is that at the moment there's money for a mentoring system for young doctors that come out of WACHS, and they've got their degree in the first year to help them get into the workforce and have somebody there to mentor them and support them through it. I'm advocating that in fact that money is also spent on isolated doctors, and that we set up a mentoring system with the regional-based FACEM or DMO or colleagues, that they can be funded to spend, have a chat for an hour once a fortnight or once a month or something like that, go through stuff, particular subjects or difficult cases, and they're just there to help out. And I think that would be wonderful. Again, Command Centre, the ETS, there may be a role for mentoring through that. But I would love that to be combined with what we're doing, because I don't think we can't tighten up the clinical governance without offering other supportive bits with it. So anyway, we had a chat with Rural Health West and the Medical Education Unit for WACHS recently, and we were all on the same page. That seemed like something that we should put money into. So that's going to be developed alongside this. How much people would take it up is another question, though. And who would be the best person? If you had me as a FACEM being your mentor, would that be less attractive than having a GP ED colleague who's very experienced in the area, who maybe it's less confronting having that than having a FACEM doing it, And so we need to think about that. And again, we may tailor it to individual people, So we have a lot of sites every Christmas, but all during the year. There are some sites that struggle to get doctors all the time to cover their EDs. We have, during the festive season, we've had to bolster the pay to locums, give them a little bonus just so we can get people to cover smaller sites during those periods, or even some of the larger sites. So is this going to make it harder? And I always really struggle with this idea of one site saying, well, we'll pay you an extra $200 to come on top of the already really generous pay to locums just to fill that site, and then it just keeps up in the ante and it goes more and more expensive just in a competition thing. So we talk about that a lot at a DMS level. I think it's really hard. This is one of the other areas that I think it's my job with this ED clinical lead thing to try and work out how we do this better and how we attract people to our sites. And are there other things to do? Is the mentoring program going to help? Because, I mean, I don't know about you guys, but I imagine we're all the same, that working in clinical isolation is far less pleasant than bouncing things off a colleague. And I hate doing ED by myself. Well, I don't hate it, but I much prefer ED when I've got guys around that I can say, what do you reckon? Is this, am I totally barking up the wrong tree here? That helps so much, doesn't it, to enjoy the job? So whether the mentoring program can help with that, we've talked in WACHS about whether there's some room with this, if we're tightening it up, to offer more support in terms of the CPD courses financially, because some of them are incredibly expensive. And just simple things like we've had people feedback that they've gone out and done locums and the place they've been given is shitty and nobody was there to greet them and they just turned up in some place they'd never been before and there was a key left under a doormat or something. So simple things that we can do to make that better is important to talk about and then try to sort of spread that word out. So because we rely a lot on locums and we've got to be smarter at how we do it, particularly if we're being tighter about our clinical governance. I guess I'm kind of trying to wind this up. The evolving questions also around, as we've talked about, ETS's role. They've just passed 100,000 cases. They've got 100 doctors on board now. Initially it was all FACEMs, now it's sort of senior registrars and things as well. Just to get the numbers up, they're providing night cover now as well. I've got a mate who lives in London who does it, who's an Australian FACEM who just sits there in the afternoon and does it for our night cover. Again, we're using it a lot for service provision when we don't have doctors around, and is that right or not? It's tough on ETS, and again, all the supportive role we've talked about in terms of mentoring, clinical reviews and so on that ETS might take up. So that's an evolving space. Be a really interesting one to see how it sort of changes over the next couple of years. The other things I'm just looking at really quickly, this is totally off our subject, but it's nurse practitioners too, and in many ways they've always been under nursing governance and they're part of nursing roster, and there's an interesting thing that occurs in one of our hospitals where, because they're part of nursing FTE, when they work in fast track, we don't have a fast track nurse, and then all the doctors slow down because they're doing their own dressings and injections and they don't know how to do them. And so we're looking at whether they should be brought under our medical credentialing model, because they very much work within our scope of practice quite a lot. So that's I'm looking at that area as well. And also equipment, and it's just a really last comment that we came across something interesting the other day that I just thought I'd mention, that we found that a few of our sites in the southwest have Oxylog 1000s that can't do NIV and don't have Hamiltons, and most other places do, or Oxylog 3000s. And that we had a patient who was sitting in one of those who had a deterioration of their COPD, got really sick, needed to be transferred, 5-hour wait for an ambulance, just had oxygen and nothing else, so no NIV, so she deteriorated while she was sitting there. And so I think another important part of my job is to try and identify where we've got real deficits in what is now core care, really. And not only providing the equipment, but also the education and support that needs to go with that to make sure that people can put NIV on, or high flow nasal prongs, whatever it may be, and look after their patients in pretty standard care sort of scenarios like that until they wait for transfer. So I'm looking out for that sort of stuff as well. So if you've got things that are particular deficits, that feel free to get hold of me. So that's the sort of stuff I'm getting at. So this ED clinical role, I'm contactable through Global, obviously, through Global Health email, and my job is to try and standardise and make sure we can just lift everything up a little bit more. So if you identify things like that, email me, because if you say it to me, I'll just forget, because I'm Dory. But if you do that, then I can look at it and push it forward. So we're pushing this lack of Hamiltons in these hospitals now, and trying to get them and get the upskilling for them. And then there's the education to the docs around how to apply them. But ETS will often, the doc will help apply it if there's somebody on site that can do it and the equipment's there. So anything like that, get hold of me. WACHS is, as I said at the start, is trying really hard, and I think, commending them for trying to engage in the the GP space, sort of being, because there's been complex things with that. Busselton was complex in that, in terms of where the GPs used to work in the hospital, and then the SMPs came in, and it was a tricky gig. I think anything we can do to engage better care in our and that GP relationship with WACHS is vital. So use my role, all the other clinical leads, there's lots of us now for different specialties, use them, get hold of them, identify issues that they can then progress, because they're all decent people and they're trying hard to do that. I guess part of it is that the regions have different needs and requirements to some extent, like the north is different to the south, and it's a totally different landscape medically. It would be really nice. A lot of the people are shared in the case ops between, like in the south, anything below the whatever parallel it is. What is it?
26.
Yeah. There is one of the EDMSs, so the medical directors, and that's Andrew Jamieson, who you'll be hearing from this afternoon. And he comes to all our case ops, and Phil Montgomery often does the northern ones. So there's common people in them. I guess it's a really good question probably to put to Andrew this afternoon, because he's going to talk about WACS structures, and it would be in his ballpark to talk about why they can or can't do that, or whether it's a good idea. So I'd really, in a really clever way, like to deflect that to Andrew. Right, so that's what I got at this morning, and WACS is trying to improve that. So, for example, in my region, I'm trying to get everybody credentialed for every site in the southwest, so that we don't have to go through. So each time it comes up for new credentialing, we whack the whole group on. And I think a lot of people are trying to do that now, which will cut down everybody's work quite a lot, everybody being you guys and us.